first.
Okay. And how does a root canal affect crown and bridge work?
Well,
where does that come into play? First of all, what is a root canal? Maybe you can explain that to the audience. People
Sure.
have to have a root canal. Oh my God. Go.
Okay. Root canal, inside each tooth is a chamber where there's nerve tissue, and it extends down into the root structure.
Okay.
And it has a very poor blood supply because it's like a little tiny opening at the end of the root. And that's why when something happens to the nerve in the main chamber, usually the body can't heal itself. Right. So root canal goes into the chamber and cleans out all of the tissue in the chamber and the roots and fills it with rubber. That's essentially what root canal is.
Right.
Well, one of the pitfalls of root canal teeth that have had root canal treatment is that they become more brittle because there's no more moisture supply to the inside of the tooth. Mm-hmm. So a lot of times when you try to put posts in these teeth, they fracture, and that's the end of the teeth. And so I don't put posts in teeth. And because I go below the gum and get a good grip on the root, I don't have to build them up, and I can save these teeth.
Great. That's great. So does that's going to affect the bridge work that's going to be eventually done, possibly?
Yes.
You have a better support system.
Yes.
Right?
Mm-hmm.
Okay. So what is precision attachment partial denture?
Okay, precision attachments, partial denture is a removable prosthesis that replaces missing teeth where there aren't enough teeth for fixed bridge work. And most people get hooks on these removables, which
right.
sometimes are visible and sometimes aren't visible. And they're called clasps.
Yes.
And the problem with clasps is that they place lateral forces on teeth, and it acts like an orthodontic appliance. So eventually the teeth are lost because they're being moved back and forth as the person wears the prosthesis. Sure. So they're really transitory to a denture. Mm-hmm. So really, as the teeth are lost, you keep moving the clasp up until you end up with a full denture.
Right.
See, now a precision attachment doesn't function that way.
Okay.
See, teeth can take vertical forces, they can't take lateral forces. Mm-hmm. So a precision attachment is a key and a lock. And the lock is part of the fixed bridge,
right.
and is permanently fixed. And the key is part of the partial. Mm-hmm. And it's machined, precision machined, so that you could take any key and it fits that female. Okay.
Right.
And see, the problems with removables is getting it to stay and resist the forces of gravity and the forces of chewing and everything without coming out. And that's why all of the attachments that have been developed usually are types that lock or grip or in some way apply forces to the teeth. But a good precision attachment case doesn't do that.
So what is that exactly?
Okay, I have a picture here. Okay, this is an actual precision attachment case. Okay, this part here is porcelain to metal fixed bridge, which will be cemented in the mouth, and this is the removable, and this fits into the bridge work. And nobody can tell how many teeth this patient has. And see, the way this stays in, this is really cool, is that it's tilted in two directions. And when I mean tilted, I mean the path of insertion is tilted in two directions. Right. So that if a stress is applied to it, it can move slightly to relieve the stress, but it can't come out. So you wear it 24 hours a day, nobody knows you have it. And these cases last longer than fixed bridge work cases. And it was invented in 1906, so it's got a really long track record. And the earliest case in our office was done in 1950. And they're just the best cases, but rarely offered to patients.
Okay, so let's take us into implants now, okay? Instead of, let's go off topic from that and go on to implants. And what is an implant? Why do people need them? Talk about that a little bit.
Well, an implant is like an artificial tooth root.
Okay.
Okay, when somebody doesn't have any teeth, you can place titanium implants, they're called fixtures, into the bone. And once it fuses with the bone, you can uncover them and you could screw restorations into these implants. So it's the closest thing that we've come up to replace teeth that have been lost. And like everything else, they're great where they're indicated, but they're not a panacea. So just because you have missing teeth doesn't necessarily make you a good candidate, because it all boils down to engineering. See, if you're going to build a bridge across the Hudson River, you would want to make sure that the supports are long enough to support that bridge.
Sure.
And it's the same thing in the mouth. So you want to make sure that you can place implants that are long enough that you can build bridge work.
Right.
So in certain areas of the mouth, you have places where you can place long implants, and in other places that people are not good candidates because you can't place an implant in long enough to support the bridge work.
So can a patient come in and say, if they have one missing tooth, they can get one implant? Or if they have bridge work already and they have no teeth in their mouth, what would happen there?
Well, that's one of the problems that I see. I think if you have a totally virgin mouth and a tooth is missing, that's an ideal spot for a single tooth implant.
Right.
But I think too many times people are getting a piecemeal approach where the implants are being placed and the teeth are all falling apart all around the space where the implant is. And that patient would be much better off with crown and bridge work, where you could do something good for the whole area, compensate for the bone loss and get rid of the decay and create ideal architecture so that they can hold on to their teeth for the whole area. So I'm interested in, if you're going to place implants, what's going to happen tomorrow.
Yeah.
I want them to end up with something and not have a fiasco later on.
Okay, without being redundant though, if someone already comes into your office with bridge work, that they're using some of this adhesive, their best approach might be to get implants. Now, if you've lost 16 teeth, do you need to put 16 implants in, or can you do it in a different way?
Yes, there are a lot of options that you can have for implant therapy.
Right.
And it doesn't necessarily mean that you have to put in 1 million implants in order to have fixed bridge work. But it really depends on which option is right for each patient. The worst thing we have in dentistry is a lower denture, because the muscles of the tongue and the cheek lift it up.
Right.
And you could put as few as 3 implants and make a great case for a patient like that. Because we're making these precision attachment cases on only 3 implants. And this differs from what mainstream dentistry is doing, making an overdenture. You could see here the difference between this, which they put more implants in very often and it snaps on, and something like this where the fixed bridge is becomes fixed in the patient, and the removable is in the back, just like I showed you on this. Instead of on natural teeth, it's on implants. It's the exact same case. We've been making these cases for 17 years, and we're not aware of any other office in the country that's making these cases. But the advantages are that, first, there's no front-back tipping forces of something like this would have, the denture. The palate is open so that, or even on the bottom, so that there's no interference with the tongue and the taste buds. This patient, when they take their partial out to clean it for hygiene purposes, doesn't feel like a freak when they look in the mirror. That's important. I think that's very important. To a patient, and they can bite into anything and eat anything. So these are the best cases and relatively easy to do and the least amount of surgery to go through. And see, also, too, in the posterior or the back parts of the mouth, it's sometimes hard to place implants because the anatomy is bad.
Yeah.
On the top, you have the sinuses are in the way. And on the bottom, you have sometimes the mandibular nerve is in the way, and you can't do really good implants. So in those patients, this is an ideal case.
Yeah.
So in other patients, if they want to have fixed bridge work, they'll have to place more implants.
Oh, I see. And is it more difficult work, and is it more difficult for the patient to go through for lower implants than upper implants, would you say? Or is that not true?
No, actually, I think it's easier for the lower, because the best bone and the best place to put implants are in the lower front. And that's a great thing, because the worst thing in dentistry is a lower denture. At least we have a good answer now for those patients, whereas in the past we didn't have much of an answer or much to help them with.
And over time, some patients might have one bone, jawbone, etc. And is there ever a time you say, that bone is too weak, not strong enough for us to even put an implant?
Absolutely, all the time, because whatever I do, I want it to work.
Yeah.
And if they're not a good candidate where you could put good long implants in, then they shouldn't have them.
Right.
Because they're just going to have an engineering failure.
Yeah.
You could have implants that fuse with the bone, or what they call osseointegrate, perfectly.
Right.
And if you overload them, like any engineering structure, that's going to fail.
And that's where the whole initial consultation comes in, when someone walks in your office, take me to someone walking into your office. Hey, doc, I'd like to get some implants. I think it's going to help me. What would the doc? Would they have to go to a consultation, and they go to the X-rays, etc., and that whole thing? Right?
Yes, I will do all of that first and analyze everything, and I will also get a consultation from the surgeon who's going to place the implants.
Right.
And then we decide what the best options are, because there may be more than one option.
Yep.
And I help the patient choose the option that's best for them.
Sure.
And when we've decided what that is, then I make my own stents. See, I have my own laboratory, and in fact, I pour all my own models, make all my own dyes, and make all my own stents for implants, and process all my own partials and dentures, which is very unusual. But it allows me to communicate to the surgeon exactly where I would like these implants placed, because I'd like them to make sure they're placed properly, and if I can, I'd like to have the screw holes, because the implant restorations are screwed into the implants, accessible, because if something goes wrong, I want to be able to take that off so that the patient doesn't end up having to cut everything to smithereens and make a whole new case.
To start, sure.
To start.
Yeah.
So those would be the initial steps. So I usually will write out the whole thing for the patient, and I'll tell them what's good, what's bad, what I think they should, what their choices are, and what I think they should do.
And it seems like it always goes back for us doctors to go back to the diagnosis. What's the correct diagnosis of the problem? And we got to find that out first, then we have the solution.
Absolutely.
Right? So before we end in the next couple minutes, Doc, let's just, as a dentist, okay, we were talking a lot about restorative dentistry, and that was the topic for tonight, but just for those parents out there who want to start taking care of their children's teeth, when should they start having their teeth cleaned? When should they start going to a dentist? Just as a general question.
Well, I don't do children, but I think generally they should go very young in order to familiarize themselves with the dental office.
Yeah.
And see, I think a good pediatric dentist, if they go to a good pediatric dentist, those dentists can maybe take advantage of the growth process to minimize orthodontics and keep an eye on that child as they're growing. But I think, maybe 2 or 3. They should, when they start getting their teeth, at least go and familiarize themselves with the dental office so that they become comfortable with it, and that they don't end up with a fear of dentistry, because dentistry doesn't have to be an unpleasant experience. I want it to be comfortable for all my patients, and I think if you start people off on the right path, then they'll have a good experience with dentistry. Yeah,
and that's great, because so many people, I don't want to go to the dentist, It's like almost like I don't want to go to chiropractor. That's old stuff now. We don't want to talk about that,
Yes.
So, hey, Doc, it was great to have you on the show.
Thank you very, very much.
My pleasure. Very informative. And I want to thank the audience for being so attentive, and we'll see you on the next show. If you have any questions for Dr. Feinberg, please email him or email me or go onto his website, and he'd be happy to get those questions answered for you. And have a good evening.